Please.
Bismillah ar-Rahman ar-Rahim. Now the next speaker is Dr. Craig Smallwood. The lecture is about capnography in the neonatal pediatric population.
Whew, last one. It's been a great conference. I hope you guys don't hate hearing my voice. Don't hear my voice in your sleep. It's been a real honor to be here. But I'm going to leave you with something that I have always been interested ever since I got into to medicine and has continued into my research, and that is capnography in the neonatal and pediatric population. This is going to be the theme of the workshop following the conclusion of today's session, as well as after lunch. But capnography, so objectives, I want to leave you with some really important tools. I think this is probably the most practical thing that I'm going to leave you with all of my time with you. But we're going to identify differences between a normal neonatal and a pediatric capnograph. And I think that for me, the most important thing is understanding what is expected or what is normal. And then any deviations for that, assuming that you really understand the basics, the fundamentals of what the normal should be, it's going to make it a lot easier for you to pick out what's wrong and figure out what's incorrect with your patient. So we're going to also talk about there are all kinds of abnormalities in terms of what a capnograph looks like, but I'm going to talk about 4 that I think are important and kind of my favorites, and then list expected VCO2 values, and that's really a little bit of a overlap with some of the talk I had earlier today. But CO2. So one of my mentors in critical care, he's the chief of the clinical department. He doesn't do so much research, but he says, Craig, if you only had one monitor, what would it be? And most people, I think, would choose probably SpO2. Oxygenation is probably the most important, maybe blood pressure. You think about vital signs. And he says, honestly, if I had to choose one monitor on any critically ill child or infant, I would choose end-tidal CO2 because it can tell you so much about your patient that is more difficult to detect than oxygenation. So CO2, you can look at obstruction, CPR quality, cardiac output, spontaneous respiratory effort, pulmonary perfusion, artificial airway placement, confirmation of endotracheal tube placement. A couple other things, return of spontaneous circulation. So as soon as you've done CPR, you're administering good quality, but then you can also tell on the CO2 when you have had a successful result of your efforts and the patient has responded. As well as nutrition titration and ventilation. So this is where we're going. It's going to be a good ride. We're going to start with capnography. So to define it, we all know this, but it doesn't hurt to just rehash it one more time. Capnography is the graphical display of the partial pressure of CO2 plotted against time. So it's a picture of CO2 and time. Capnometry is another term that you may hear, and it's often used synonymously with capnography, but to be honest, and most truthful, capnometry is really just the integer, the value. So the end-tidal CO2 value of, let's say, 35 millimeters of mercury, that would just be capnometry. If you have a picture, now that's also capnography. And the units, a couple here, thank you for using units that I am familiar with, because that makes our lives a little bit easier. But indications, so these are, I pulled from the data, these are actually ones that I think that you can lean on some good clinical investigations to support its utilization. There are all kinds of things that we do in medicine that is not necessarily as a result of good research. That doesn't mean it's not the right thing to do, it just means we haven't proven it yet. But here's some that we can feel pretty good about. So endotracheal tube placement, obviously intubation. One of the things we do as standard of care, I don't know what your practice is, but any infant or child or anybody who gets intubated or in the ICUs, we will have an end-tidal CO2 device ready and warmed up, because sometimes they can take a little bit to fire up. As soon as that endotracheal tube is placed within the airway of the patient, we affix that device and look at the waveform. So what we want to see, and we'll come to this when we look at some illustrations of what it looks like, but you guys know what it looks like. It's just like a nice sharp rise in CO2 up to a level that's it's probably around 30 to 50 or so in that range. Might be a little bit plus minus, but that's generally our indication. If you intubate the stomach, the esophagus, you can sometimes have a little bit of an increase in CO2. There is CO2 in the belly a little bit, and sometimes with positive pressure mask ventilation, you can force some gas in there, but usually it doesn't have too much CO2 in it, so we wouldn't see much of a change on the CO2 waveform itself. And also in transport, and that's really just a safety thing, we actually monitor on 100% of our intubated patients, unless they're a really small newborn who we're not really comfortable with putting a large adapter on their airway. If it's gonna, it can be a little bit cumbersome depending on what the device is you're using to aspirate a CO2 sample. But if it's too cumbersome, that the baby's just too small, sometimes we'll just spot check it a handful of times a day. But otherwise, if they can tolerate the dead space, if they can also tolerate the weight of it, it's not gonna rip off their endotracheal tube, then we'll monitor it continuously. And that allows us to ensure that endotracheal tube is in the correct place. So CPR quality, anything less than 10, almost across the board is poor quality. Return of spontaneous circulation, you'll have a marked increase in CO2. Post-anesthesia, you'll see a fair amount of anesthesia recovery units. So post-operation, they'll go to anesthesia recovery, even non-invasive. Folks will oftentimes use a nasal cannula, and I don't have a picture of this, but you've seen the nasal cannula where you aspirate a sample and you can get a capnographic waveform and a value. The values are used a lot less than on an intubated child because you're entraining a lot of room air. But what they'll do in this case is to ensure that the patient doesn't have a hypoventilation event and therefore a hypercapnic event as a result of their sedation or anesthesia plan. It can be an early warning sign and much earlier than oxygenation. So you'll see a lot of indications like that. Pulmonary circulation, it can detect changes sooner than oximetry, not even VCO2. So I spent a fair amount of time talking about VCO2, the flow of CO2, with just end-tidal. You can get some indications as to whether or not you've improved or worsened your pulmonary circulation, your pulmonary perfusion within the lungs. And adequacy of ventilation, I think that's probably the principal reason we use it, is just to get a assessment of ventilation during the time period between blood gases. And honestly, we don't even get that many blood gases. If you get really comfortable with using end-tidal CO2, you'll find that your requirements for getting an ABG or even a VBG drastically reduces. It takes a little bit of bravery, and I think it's something that's evolved in our practice over a number of years, but that is essentially it. In the acutely ill, absolutely, you're never going to not get a blood gas if it's not indicated, but the number can be reduced. So one of the things that's really interesting practically is the gradient between arterial and end-tidal CO2. So PaCO2, that is the partial pressure of CO2 in the arterial blood, is what we see in an ABG. And that is what we want to assess when we get end-tidal CO2 most of the time. So if we have an end-tidal CO2 value that's climbing, what we want to do is say, like, well, that's probably pretty close to the PaCO2, and we should increase ventilation to make sure that comes back down to a level where we would have a good pH and a good CO2 level. The problem is there's always a gradient, and correct interpretation of that gradient is important for clinical utilization of the tool. So this is, you can't really see, this is really kind of dark here, but this is basically my attempt to illustrate why we have a gradient at all, why there's a gradient between the arterial and end-tidal CO2. So we have a tank, and a portion of this tank is filled up with a partial pressure of CO2. You can see the partial pressure is 40. And that is analogous to the alveolar ventilation. We know that we have some dead space ventilation where we inhale the gas, it's conducting airways or perhaps alveoli that don't interact with enough blood. That is a portion of the gas that does not participate in gas exchange, dead space. But there is a large part, hopefully large part, if our patients aren't dreadfully ill, that the gas interacts with the alveolus, picks up CO2, drops off oxygen, and that's what we have. So, no gas exchange during the dead space. We have a part that is the arterial gas. It's perfused alveoli. We put those together. I'm going to shake up this tank if my animation works. There we go. And there's supposed to be a little bit of a difference between these colors, but you can't really see. But you average those out and you get something that's about 35 millimeters mercury. That's why we get the difference. Oop. So here's the important piece. So the gradient, PaCO2 minus P end-tidal CO2. Normally, in healthy neonates and children, it's anywhere from close to 0, it's usually more than 0 to be honest, up to 5 millimeters of mercury. So that's the expected gradient between PaCO2 and end-tidal CO2. That gradient can change. One of my pet peeves, I think, as a researcher who spent a lot of time thinking about these things, and also an RT working with clinicians and physicians at the bedside, is when people say that the end-tidal CO2 does not correlate with the PA CO2. Well, in the purest sense, they always correlate, but what changes is the proportion of dead space. So as your dead space increases, so if you increase that fraction, and a normal dead space in a healthy newborn or child is probably around 30% of the tidal volume. If you increase that proportion up to 40, 50, sometimes even 60%, then the gradient between the end-tidal and the PaCO2 increases. So really the gradient's telling you something pretty important about the physiology, the pathophysiology of your subject. So during obstruction, it can be an indication of impaired exhalation, and during restricted disease, it's principally an indication of dead space ventilation and poor VQ matching. Okay, so I have a special device. I'm going to get my phone, and I'm going to show you what a normal CO2 waveform looks like, hopefully. I'm just kidding. I'm just kidding. It's an animation. But that's basically a normal CO2 waveform, where I think we're pretty familiar with that. That's probably a more term newborn or a little bit of an older child. But we're going to look at some of those, as well as the abnormal here. So obstruction, rebreathing, spontaneous effort, or dysynchrony, that's an important issue, I think, across the board, especially in newborns who have difficulty triggering the ventilator sometimes, and cardiac oscillations. So here's what the normal waveform looks like. On the top is a healthy newborn, and you can see that there are a couple of important periods. I've labeled them here. So phase 0, 0, 1, 2, 3. I'm going to step through those systematically with you guys. You will note in some of the literature, it'll start with 1, 2, 3, 4. It doesn't really matter. The reason I prefer 0, 1, 2, 3 is because 0 is really inspiration, and then you start counting once exhalation begins. So you start counting, and that's basically what is indicated by these little dashed lines. So here, patient breathes in, breath goes in. There's obviously no CO2 in that gas, hopefully not at least. And then you begin to exhale. There's hardly any or no CO2 in the conducting airways. And then we can see that there's a really sharp rise during phase 2. That's the mixing phase of the capnogram. That's basically when we transition from the airways dead space down to the alveolar ventilation. And you'll see this, the highest point here is that moment at which you're eliminating the gas from the deep alveoli, the portion of the breath that's interacting with the capillaries of the pulmonary vasculature, and getting the CO2 out of your patient. So we have, inhale, exhale, and getting all the CO2 out. What you notice, the big difference is between a healthy newborn and a healthy child is one, the duration. So the total cycle time of inspiratory to expiratory is obviously going to be smaller in a newborn. And I should note too that sometimes you don't even have a really good plateau. So one of the things that people will tell you is to look for a good alveolar plateau. And what that means is like this flat part at the last portion, phase 3 of the capnograph. And really what we do in that case is making sure that we're giving our patients enough time to exhale when you see that. But in newborns, since their inspiratory gas flow rates, their volumes are so small, and the time during which they have to exhale is so shrunk, that we sometimes don't have a good alveolar plateau, and that's honestly normal. Unlike probably a term baby or a healthy child, where everything takes a little bit more time and we have time to get a good, nice plateau. But we have same thing. Inhale, begin to exhale, conducting airways, mixing phase, alveolar phase. Nice end-tidal CO2 right here. And the measurement, there's a couple of differences in how the technology is applied, but in its purest sense, the end-tidal CO2 value, the number that you see, would be ascertained right here. So at peak exhalation, right before the next breath begins. Okay. So we're going to look at obstructive capnography. By the way, all these things, I made a lecture, if you guys have heard of open pediatrics. It's a website that was really spearheaded by colleagues of mine in the Department of Critical Care Medicine to share basically our practice, and from experts around the world. We try to bring as many people in as possible to lecture, to share guidelines, to share information, so it's readily accessible and free online. So if you go to openpediatrics.org, you'll be able to get access to this stuff. You just have to sign up. It's a really simple, free little profile you set up with your email, and you can watch all these videos online. I have one that's on capnography specifically. So a lot of what I've said today, if you forget tomorrow or next week or a year from now, feel free to log on there and listen to it all again. All right, done with the commercial for OpenPeds. So the obstructive waveform pattern. So we have inspiration, and then we have a really kind of relaxed and almost like a ski jump type formation here of the alveolar, the transition, and we don't really see much of a plateau phase. So we're not getting a good exhalation. We're not seeing a lot of alveolar gas deep within the lungs being exhaled. And that is because there's a severe airways obstruction that's limiting airflow, and we have no idea what the airflow is during capnography necessarily. All we know is the partial pressure of CO2. So this is what obstruction would look like, just like that. Compared to the normal, you can see exactly what I just said. Basically, the lengths of each of these portions of the capnograph are really kind of messed up. So phases 0 and 1, really no difference. But then phase 2, you can see we're spending the bulk of the time in phase 2. There's honestly just not that much CO2 in that portion of the breath. So that's why these patients with severe obstruction, whether it be bronchiolitis or asthma or what have you, mechanical obstruction, doesn't matter. The reason they can't ventilate well is because they're not getting rid of their alveolar gas. So what about rebreathing CO2? That's an easy one to pick up. I said hopefully none of the CO2 is being inhaled, but sometimes with newborns with rapid respiratory rates, perhaps if you're unable to get to high frequency oscillatory ventilation in time, you're cranking up the respiratory rate to improve ventilation, and you may see yourself in a bit of a pickle, and it looks like this. So if you don't give yourself enough time between the breaths, you could be leaving a little bit of CO2 in the dead space, the mechanical dead space, so the portion of the ventilator circuit that may have a little bit of CO2 in it, and you inhale during that next breath. And that's essentially what it is. The way it looks is basically just an elevation above baseline. So you can see really we want to start inhalation at 0, and this is a little bit elevated above there. So patient effort. Dysynchrony, ventilator asynchrony, whatever you want to call it, I think it's increasingly a problem in the adult literature. They've kind of spearheaded this, and we have always been, I think, very sensitive to ventilator asynchrony during neonatal and pediatric ventilation, because the devices that we use were usually kind of built mostly for an adult population, and we're trying to apply it to our children. So in order for them to generate a negative pressure or a flow difference during ventilation, a lot of those breaths can be missed if the respiratory effort of our patient is subtle enough to not be triggering the mechanical ventilator. So in that context, what we want to do is either adjust, we can adjust the trigger sensitivity. So usually we use the negative pressure and or the flow trigger. So you don't want to auto cycle. So if you set it too sensitive, the ventilator could just be tricked into thinking there's always an effort. And you also don't want to be too insensitive that we miss these breaths. And so these missed breaths we can pick up on the capnograph as well as some of the ventilator graphics as well. But this is what it may look like. So you can see here that we have, I'm going to look at this one right here with all the nonsense written on it. But we inhale, we begin to exhale. Everything mostly looks okay except for these little dips. And we see like these periodic little decreases in CO2 during phase 3 is usually the easiest portion of the capnograph to assess that. But basically, it's the patient taking a little bit of an inspiratory effort while the ventilator is trying to exhale. And so you can see there's a slight decrease in the CO2, and that's how it manifests. Okay, last one, and this is one of my favorite ones because it looks so messed up. It looks so weird, and the first handful of times that I saw this on the capnograph, I was like a little bit disheartened and a little bit anxious about what it meant for my subject, and I'll tell you why that's a little bit funny in just a minute. So this is, we're looking at cardiac oscillations, and so you can see the animation basically is stepping through inspiration, transition zone, plateau, and then at the tail end of the alveolar gas phase of the capnograph, we see this periodicity, kind of up and down, and it's also decaying. So the partial pressure of CO2 is kind of like getting less and less as time goes on. And you can sometimes see that this goes all the way down almost to zero before the next breath starts. And what's happening is that at the end of exhalation, there can be very little gas flow. And sometimes it will manifest in a patient who has a heart that's beating strong. A lot of times we'll see these in our congenital heart disease patients. And the heart basically is moving gas inside the thorax. So it's pumping enough, it's making enough of an airway disturbance that we're seeing these little oscillations in gas flow. What you can do is just kind of count the periodicity, and if it's basically exactly what the heart rate is, well, it's cardiac oscillations. And I told you that the first handful of times that I saw this, I was really anxious and I didn't know what to think of it. And I thought it was like going to be a dreadful finding for my patient. Well, it turns out this doesn't really matter that much. So it's not a big deal in most cases. So long as you have adequate ventilation and no other clinical problems with the patient. If you saw this, just don't get worried. And that's basically the summary of that. So a couple of things on volumetric capnography, and then we'll close our time together. But volumetric capnography is a plot of CO2 concentration. Rania asked about how you calculate these things on the ventilator, but it's a plot of CO2 concentration versus exhaled tidal volume, unlike capnography, which is CO2 and time. So VCO2 is a volume of CO2 that's coming out of our patient per unit time. These are the units we can talk about. I said that I am always gravitating towards mLs per kilo per minute, but you can also look at mLs per minute and liters per minute. And this is actually data that I collected on a newborn with congenital diaphragmatic hernia. You can see here is the fraction of CO2. So basically like 2%, 4%, 6%. And you can see here is the total tidal volume. So as the tidal volume, the exhaled volume is coming out of the patient, we're simultaneously measuring the CO2. And this is what the machine does. So at each time point, it's going to record what the CO2 is until we get to the end of the breath. So tidal volume about 12 mLs. And so what you can do, what the machine does automatically, is calculate the area under that curve. So you're just multiplying the volume times this fraction, and that gives you the CO2 elimination. So another thing that you can do with volumetric capnography, if you guys read any of the literature or look at some of the lectures that I have on open pediatrics, people will talk about interpretation of the volumetric capnogram. And so what you can do, it looks very similar to time-based capnography, but it is distinct. And I'll tell you for a couple of reasons. You can find out some really interesting things. So we begin to exhale. We go here. This is airway dead space. You can see that's labeled. At some point, we kind of transition. We've amassed enough concentration of CO2 to call it alveolar gas. And then basically from here, the volume is increasing. This is obviously an adult because this is a pretty big tidal volume, but dead space gas here, 200 mLs. Then enough gas, 200 to let's say like 900 is alveolar gas. And what you can do is then calculate automatically on the ventilator the proportion of alveolar ventilation, which can be a helpful metric, as well as assess VD to VT, so dead space to tidal volume ratio. Indications, pulmonary circulation, dead space, and vent titration. I showed you a couple of interesting illustrations of that earlier. And I think one of the last things I'm going to leave you with is dead space. We all know what dead space is. And how do we calculate dead space? You guys learned about this, I'm sure, in school. VD to VT. This is the Bohr modification of the Enghoff modification of the Bohr equation. And basically, VD to VT, so volume of dead space to tidal volume, basically a fraction. We take the partial pressure of CO2 in the arterial blood minus the average value during the exhaled breath over PaCO2, and that calculation yields our VD to VT a fraction. So that's important in infants and children because people have looked at that metric as a risk factor for a number of things. So it can predict successful extubation, and this is some data here from Duke University. And you can see here that the fractions of VD to VT, so basically 50% or less, the failure rate for extubation was pretty low. And then once you start seeing patients above that 0.5, 0.6, the probability over here of extubation failure increases. So it can be a helpful metric perhaps as part of an extubation assessment. Okay, so last couple of directions. I know that this is like in the future, but I try to always keep my head a little bit in the future because I'm a researcher, and unlike you guys who are able to make a difference every single day, I have to labor and toil and hopefully make a difference a decade or 2 decades from now. So I'm showing you a couple of studies I think are representative of some of the work that I'm going to be getting into, not my work personally, but that are going to take these data and make it easier for clinicians like yourselves to apply this stuff to make clinical decisions. So this is basically taking capnography and coming up with a prognostic index to detect severity of asthma automatically. So this is some data from this study. So we have a normal capnogram up here. This is real data from one of the subjects they enrolled. And this is the capnogram of the obstruction. And that looks remarkably similar to what I showed you with that animation. So you can see there's a delay getting to the alveolar plateau, or really absence of alveolar plateau. And some people have called it a shark fin. So that's a good way to describe it. Unlike a real shark fin, you don't want to run away from this one. You kind of want to fix the problem. But the process that they use is here. It's really kind of like a machine learning and data mining process. But what they wanted to do is come up with an algorithm that can automatically detect this shape or the deviation from this as a function of severity of asthma. And then now you don't need to subjectively interpret this with your own eyes, but the machine could perhaps alert you that you need to come look at your patient because the obstruction is worse, or maybe it's getting better in either case. And you can see here what they did was calculate the sensitivity and specificity. They looked at the stratification of severity of asthma over here. You can see the true positive and the false negative rate. So the bigger this number, the better. The smaller this number, the better. And you can see that overall it was pretty successful. And then the sensitivity and specificity compared to some other metrics of assessing severity of obstruction. So this is their performance here to some other benchmarks that you see in the literature. So I think this is representative of the direction that I think you'll see some of my publications coming, is kind of automating a little bit of these things and supporting some decisions so that not everybody has to look at the ventilator at every single moment. Some of the work could be done automatically by an algorithm on the ventilator itself. And then last one. This is these researchers who published this in respiratory care, obviously, in children with hypoxic respiratory failure. What they wanted to do was kind of automatically detect or compensate for those gradients that we talked about. So remember we talked about the PA to end-tidal CO2 gradient and how it can be a little bit tricky to clinically interpret at times. What they wanted to do is to find out a method to do that automatically for us. And I'll leave you with this slide, but essentially they weren't that great. I think the general sense is like these red dashed lines are actually really close to this black line, is where you'd like to see all these little blue circles. So they have the actual CO2 here, their methodology here of predicting PA CO2 based on some risk factors they looked at in the medical record of the patient. And you can see really the performance is not that strong. So what this means to me, it's a little bit encouraging because there's some work to be done, but I think that's where you'll see myself and my colleagues moving to support you guys in that type of way. And that is it. Thank you so much.
Thanks, Dr. Craig. Now anyone can ask a question.
Okay, Dr. Hisham, تفضل.
Thank you for the lecture. I've got two questions for the two lectures.
Okay.
The first question, can we use the thoracic impedance to estimate, as a tool to estimate the optimum lung volume during high frequency ventilation to avoid the overdistension? The second question concerning the capnography, I've thought about another benefit when you are stuck with a bronchopulmonary dysplasia where the production of CO2 is essential, and when you try to limit the production of CO2, for example, by using more lipids than carbohydrates, and this will allow the reduction of CO2 production. The exhale, if you are using monitoring of CO2, that would be a good marker of your success in reducing CO2 production.
Yeah, so I'll answer the first question first. But so the question basically is, can we use EIT, so lung imaging, to optimize ventilation during high frequency? I think that I couldn't point to any strong data in neonates using the oscillator that would suggest across the board that we should just drop everything and buy EIT boxes. But I do feel fairly strongly that it tells us something pretty important that we otherwise are missing in our clinical assessment using pulmonary mechanics, or even if you're fortunate to have gas exchange attached to that. So I think there's going to be a select number of patients that we'll see in the coming years whereby publications will prove to us, like I demonstrated with us looking at specific regions of interest and saying, here's some data that we had no idea about previously that can help us to differentiate patients who present clinically in a similar manner but have a difference in terms of their response to therapy. So I think I'm kind of avoiding the question, I think, a little bit, and I would hesitate to say yes or no, but I would feel pretty good about in the coming days that we will figure out how to do that. But right now, I wouldn't feel confident enough to basically write a guideline. And so if you ask me, say, like, let's do this, let's make a guideline, we'll purchase the equipment, and then this will be the clinical practice from here on out, I don't think at this point I would feel comfortable doing that. But in the coming years, certainly, I think it's just around the bend. And then the second question is about BPD, and this is, I think, is an important patient population in terms of nutrition optimization and not inducing a CO2 burden. I think that's exactly the case that you've outlined. The general point, I believe, is that in all patients, I think it's important to try to match as best you can the amount of energy that they're burning with the amount of energy that you're prescribing. The important thing, though, to take away from my experience is that not all patients matter. I think that 95% of the patients who come in and through the NICU or the PICU, you can probably get away with estimating equations and it doesn't make a difference. But BPD is an important population because these patients have a condition that makes it very difficult for them to wean from the ventilator, to get out of the NICU, to get home and live a life. And so I think the philosophy in that case would be if you had VCO2 monitoring, that would probably be the best estimate of energy in those cases and probably a decent indication to match the burning or their use with the titration of the nutrition prescription. With end-tidal CO2, you can't exactly get there, to be honest. It'd be very difficult to kind of assess just on end-tidal CO2 what the nutrition should or should not be. It's kind of, the end-tidal CO2 is kind of an end result, almost, of what the VCO2 would have told you. So the end-tidal CO2 basically is just a surrogate, in this case, for the PaCO2. And so if you were overfeeding the child, you could see over time that the CO2 was climbing because you've introduced a burden, and there's always a balancing act, right? That's essentially it. So there's a production of CO2 at the cellular level as the patient metabolizes these substrates, uses up oxygen, produces CO2, and that's here, there's a level. And then on this hand, there's a level of ventilation. So we have respiratory rate, the efficiency of gas exchange, VDVT, tidal volume, all that affects that, and that's a certain level. And if what we do is introduce a CO2 burden, so the CO2 production is up here, but the patient's capacity to increase ventilation is only up here, well, the end-tidal CO2 is going to go up. And so what you try to avoid, and I think it's a little bit of a difficult task if you don't have VCO2 or a good method to estimate what the energy is. Yeah.
No.
I hope that answers your questions.
By using the fan, the respiratory motion will be 0.7 and the CO2 will be reduced. But this will be reflected in the expiratory, we can detect it?
The VCO2 or the end-tidal CO2? For
End-tidal CO2.
Yeah, so it would be, you would eventually detect it, but it would be a period of time after that. Because the end-tidal CO2 really tells you about the partial pressure of CO2 in the blood, and it's really kind of like the end response to what's going on in terms of the flow of CO2 in and out of the patient. So that's the crux of end-tidal CO2 and PaCO2.
Muhammad, Dr. Muhammad.
Thank you. I also have two questions for this lecture about the capnography. First one, for volumetric capnography, you said that it will measure, you can use it for as a measure for VD over VT, actually dead space for the total tidal volume.
Yep.
Do it measure the anatomical dead space or the total dead space? anatomical and physiological.
Yeah, so that would be an estimate of the total dead space.
Total dead space.
I didn't really go through it in detail, but at that plot whereby we looked at the volume on one axis and the partial pressure, you can actually look at the coordinates and pick out anatomic, physiologic, and alveolar volumes. So it gives you all.
You can use this technique for anatomical dead space also.
And anatomical, yes. So what the researchers have done is give you a couple pieces of information that can be derived from that plot. One is the volume of dead space, and they basically say it's just the portion that's like basically midway through the transition. So whatever volume you are until you get that like big sharp rise in CO2 concentration, that volume to the zero, that's your airway's dead space, and then after that is your alveolar dead space. That's how they label it. The total dead space, including physiologic, would be using the Bohr equation, the Enghoff modification of the Bohr equation. So that's the PaCO2 minus end-tidal CO2 over PaCO2, and that gives you the fraction.
Thank you. The second thing about capnography, even end-tidal CO2, you didn't show us the effect of leaks on this. When we are using capnography in neonatal population, we have many leaks.
Yeah.
What does leak do to the accuracy of end-tidal CO2? I think it will make the correlation poorer or make the gradient greater.
Yeah, that's a good point. I did definitely skip over that, so thanks for asking that important question. So in the case of a leak, you would definitely see a larger discrepancy, a bigger difference between the end-tidal CO2 value and the PaCO2 value. So you're going to kind of underestimate in general. I think that what you can mostly preserve is the shape of that waveform. So it's going to be kind of obliterated a little bit because you're losing gas around the endotracheal tube. It's not all going through the sensor, but what you can see is the general shape. And so that interpretation, that ability to look at whether it be obstruction or rebreathing or spontaneous inspiratory efforts during exhalations, dysynchrony, stuff like that, you should be able to detect those shape changes. But then the important piece would be interpreting, understanding that there's going to be a larger discrepancy because you're underestimating the end-tidal in the case of a leak.
Okay. Last thing about the first lecture for respiratory care techniques. You showed us the results of NIPV trial for NIPBV versus CPAP. Yes, it's the biggest trial was done with non-invasive post-pressure ventilation. It actually enrolled about 1,500 patients, but and it showed there is no difference between using NIPBV versus CPAP.
Yep.
But actually, there are two Cochrane reviews, systematic reviews with Cochrane meta-analysis. One for early use of non-invasive ventilation versus CPAP, and the other one for post-extubation, and they showed significant difference favoring NIPBV. I think this worth considering.
I think that's a good point. And one of the things I tried to leave you with was one of the limitations of that study that I showed you was they looked at basically overall, and they had a reduced capacity then to look at specific time periods during the course of ventilation or during the patient's disease process, whereby there would be differences in non-invasive positive pressure or intermittent positive pressure versus CPAP.
Actually, it was an umbrella study. It was enrolling every patient with NIPBV. So the effect will have been diluted. It was one of the criticism for this study.
Yeah. Yep.
Thank you.
Fair enough.
Any more question for Dr. Craig? Okay, we'll close. Yeah, just one question.
Last but not least.
Concerning the capnograph, you said that if the baseline doesn't return to zero, that means CO2 rebreathing, and that means CO2 in dead space.
Yep.
Actually, I think there's always CO2 in dead space unless the baby's on ventilator and inspiring 100% oxygen, or did I get it wrong?
You shouldn't have CO2 in the dead space. So so the question, correct me if I'm wrong, but I heard it basically. So I talked about rebreathing, and that's generally bad. It's generally a function of too much dead space that we've put on them. So whether it be an adapter or circuit components, stuff like that, an Omniflex, if you know what that is. If there is CO2 in that and the patient breathes it in, really I think the best solution would be to reduce that volume of dead space. And our practice is always to reduce the amount of dead space so much as we don't have rebreathing. So that's basically all you need to do. The dead space is okay, so long as it's been completely flushed and has a reduced capacity of CO2 in there. But I think the other point you're saying is because it's not necessarily completely pulled out of the subject, that you're going to have a little bit of CO2 kind of left in the endotracheal tube, essentially, because that would be another portion of the dead space. And I think in that case that you're right, there would be a little bit of CO2, but at the point where we measure it with the CO2 capnograph, the device itself, in general, we like to see those values basically zero, and most of it can get flushed out.
So it's there, but it's almost neglected, so it's considered zero.
Yeah, it would be so close to zero that you wouldn't be able to necessarily detect it or really care. But once you start that, once it gets to like 1, 2, 3 millimeters of mercury, that's when we would say, okay, we got to figure something out because we were making the
there's always
the
CO2
ventilation
in the
inefficient.
circulation.
Yeah.
Thank you so much.
Thank you. But before closing, Dr. Rania, before closing, I'm just hinting for the project of our university, and we have one of the principal here, Dr. Mariam Abu Shadi. We are lucky enough to have a running project about the safety of the newborn. It's called a network, neonatal network safety. So where is Dr. Ibrahim? I don't see him. Okay. I think it is a very important topic. Yes, Dr. Ibrahim, and we have this running project with the Timbus at Al Azhar University and other 5 universities in Cairo, and 4 Egyptian and 3 European, I think. Yes. Just one question: how many hours did you advice for the resident to spend in the working hours? Just one question, and then we'll close. Okay, I think there is.
معلش دكتورة, your questions was how many hours they need to
spent in hours, yes, in hours for the resident.
for simulation?
Not for simulation, for working hours.
For working hours. Sorry. Okay, I just got you. So as I told you, aviation, they are not allowing the flight fighter to the flight attendant to stay more than 17 hours actually. So
more than 17 hours.
Yeah, but we need to show them how we can do what we call the fatigue management. Yeah, so this is by itself, it's a course. So how can they take like a short naps, stay away from caffeine, okay, and for the load. So yeah, and the role playing, how with others also, how they can work as a team. So this is most important also, how can they manage it? This is the most important thing. But I know even in Saudi, for our residents, when they go for on-call, they will start from 8 a.m. and they will just finish their duty the second day at, I think, 1:30 p.m. So I don't know about here. It's the same. So because our teachers are Egyptian, so we have all the system. I'm sure about this. For this, we have the same problem actually, and this happens. So we have to think about this and reconsider. And it's not only about the duty. Sometimes the frequency. You have every third, every second. Sometimes this is very harsh actually for the residents. You know, it's as a regulations, it's not more than 40 to 48 hours should be per week, working hours. But we are exceeding these limits because of shortage, actually.
Thank you.
Yeah, thanks.
Thank you. It's closing.